It's a great pleasure to be here. Thank you, Leo, for the invitation. So, this morning you've heard a lot about phenotypes in asthma. You've heard a lot about COPD. Virtually everything has been said already. I've heard a lot about heterogeneity in COPD, about comorbidities. And what I will try to do is to use exactly the same words, but to give you a different perspective of what I believe is important for COPD phenotypes, really focusing only on clinical COPD phenotypes, because there's another talk just after by Professor Kriner on CT scan-based phenotypes, and I would not give any insight on biology in this talk. So, why do we need phenotypes in COPD? First, I will review current approaches of COPD classifications and why there are problems with these classifications, with the old GOLD classifications, but also with the new GOLD classification, which I don't think really address the right problems. I will give you a short definition of phenotypes. Pascal already did so it's going to be short. And I will give you an overview of ways for identification of COPD phenotypes using the clinical classical approach, and I will use the example of chronic bronchitis for this. And I will touch about novel approaches such as cluster analysis. So, current approach and limitations. For many years, we've grown with this classification of COPD, which was mostly based on FEV1 and FEV1 severity. So severe COPD, based on this classification, was really low FEV1. And this classification was used for treatment. So you know this treatment algorithm from the GOLD 21 or GOLD 2010. It's almost the same classification. And everybody remembers this diagram. So you have a level of FEV1, and then you have a treatment corresponding to this level of FEV1. Even though in the document it's written that you have to adapt your treatment to symptoms, most of the people really did not care about it. It's really FEV1 triggers treatment. So it's the same treatment for everybody. It's really the one-size-fits-all concept. But we know, and we know it very well, we've heard it this morning, but we have very good data from the ECLIPSE study showing that for a given level of FEV1, and here in the ECLIPSE study, patients were classified according to GOLD stage, spirometric GOLD stage. So this is GOLD stage 2, this is GOLD stage 3, and this is GOLD stage 4. And for any given thing that you look for, you have marked variability. For example, this is dyspnea. Even in GOLD 4 patients, you have some patients who have very low level of dyspnea and some patients with very high level of dyspnea. And in GOLD 2 patients, also in the mean, patients have less dyspnea. You have patients with very high dyspnea. And you can show the same thing for example, this is 6-minute walking distance, and this is quality of life, has already been shown this morning. So COPD is a very heterogeneous disease. So based on this, the expert from the GOLD committee had several meetings, and they end up with this very difficult classification, I think. Here you get FEV1, and then you get symptoms or COPD assessment scores or quality of life, and exacerbation here. And based on this, you define A, B, C, and D. And as was already been shown this morning, it's a problem because when you try to assess future prognosis with this classification, you have a problem between B and C for the prognosis. And the problem is mostly due to comorbidities. So I would suggest that this, which was obtained by consensus, but not based on real data, is inappropriate, and it's inappropriate for several reasons. The first reason, I think, has to do with the natural history of FEV1 decline. You've seen these diagrams thousands of times. It comes from almost 40 years ago by Fletcher and Peto, and what it describes is FEV1 decline over time with aging. So if on this diagram, you put a blue square here for GOLD 3 and 4, which means severe airflow limitation. And then you have two kinds of patients. you have patients with early disease, and you have patients with late disease. And these patients, they have the same FEV1, same level of FEV1, but they are very, very different patients. If you have an FEV1 of 50% at the age of 55, you have two possibilities. Either you are fast decliner, or maybe you were not reaching 100% at the age of 20, so you're coming from a lower FEV1. But it's likely a very different disease if you have the same level of FEV1 at the age of 70 or 75 as compared to the age of 55. And this is not taken into account neither in the old GOLD classification nor in the new GOLD classification. The other problem with this GOLD classification with the new one is comorbidities. You all know, we've heard it this morning, that comorbidities are very important in COPD patients and that they are highly prevalent. And in this paper, they listed many different comorbidities. And if you see the size of the circle, it means that the disease is highly prevalent in this cohort of COPD patients. So, for example, here, hypertension is very prevalent, coronary artery disease is very prevalent. And then if you have COPD in the center, because we have pulmonary physicians, so we put COPD in the center, what you can demonstrate is that, for example, coronary artery disease is very close to the center, which means that it has a prognosis impact as a comorbidity. So comorbidities are very important in COPD patients, and many of our patients die from comorbidities, but they are not taken into account by the new classification. So what we tried to do is really to examine the magnitude of the problem in a cohort of a large cohort, almost 2,500 patients, in a pan-European cross-sectional observational study, which was previously published by Romain Kessler in 2011 in the European Journal. So in this study, what they did, they recruited so-called severe COPD patients, which means severe airflow limitation, FEV1 was below 60% predicted. And we had physician-diagnosed comorbidities in this study. So if you look for various comorbidities, for example, left heart failure, ischemic heart disease, diabetes, sleep apnea, depression, diagnosed by doctors, and you look at the prevalence of these comorbidities in the percent of patients here, according to GOLD stage, GOLD 2, GOLD 3, and GOLD 4, you see that the prevalence of comorbidities is almost the same in each GOLD stage, at least for cardiovascular and metabolic disease. But then, to give you a different perspective on this, what we did, we classified the prevalence of comorbidities not according to GOLD grade, but according to age quartile in the study. And here you have a very different picture. Left heart failure, ischemic heart disease, diabetes, the prevalence really markedly increases with age. So this is to say that the main problem with the current approach that we have in the GOLD strategies is age and age-related comorbidities. And these are not taken into account by any classification yet. So this is probably why we need phenotypes. So when you want to know what is a phenotype, you go in the dictionary, and as already been said this morning, it's the interaction between genetic and the environment, and it gives you phenotypes. So if you think of this for COPD, what do we have about genotypes? We have alpha-1 antiprotease. It's a strong genotype, but it's only in a minority of patients. We have many different polymorphisms, MMP12 and others, but from a clinical point of view, it doesn't really add much at the moment, at least. From the environmental exposure, we get tobacco smoking, air pollutants, which may have changed a lot over the past 50 years, biomass exposure, which may be responsible for COPD in non-smokers, especially in women in the developing world, infectious agents such as tuberculosis, and we should never forget that we have also treatment, that side effects of treatments, for example, it's obvious for oral steroids, that it induces changes in phenotypes. And also, we have to remember, and we'll go back to this later on, that for now we're treating patients with drugs, And phenotypes that were described in the past, like 50 years ago, patients did not have access to any of these drugs, so the phenotypes may have changed. And then we get the phenotypes. So phenotypes could be clinical, could be a response to therapies, could be biomarkers, could be imaging, or it could be a combination of all of these. So the clinical phenotypes, gender, is there a difference between COPD in men or in women? Is there something different about this overlap of asthma and COPD, atopy, malnutrition, chronic bronchitis, cough and sputum production, comorbidities, frequent exacerbation, rapid decline in FEV1, many, many different things. You can pick up the one you like the best and say it's a phenotype, but then you have to prove it. And this was really the main contribution of this group of experts. We tried to define phenotypes as the future of COPD. They say it's not enough to be a combination of disease attributes or a single disease attribute. It has to describe clinically meaningful outcomes, like to predict symptoms, to predict exacerbations, response to therapy, rates of disease progression, whatever it means, and death. So basically, what it had to the pictures, you get genotypes, you get environment, you get phenotypes, and then you have to prove that your phenotype has some relevance to the natural history of the disease or to a response to a treatment. So potential problems with phenotypes. You all know these diagrams. They are from 1955, so it's a long time ago. At that time, patient had no really treatment. And if you look at reviews on this, they were very different patients as compared to the patients that we have today. There's a beautiful review by Thomas Petty 10 years ago, I think, in a journal. And he reviews pink puffer and blue bottles. And the example he gives are patients 55 years old and 60 years old. So our patients these days are, in many cases, older than these patients. So I think this is very different from what we have today. And basically, these phenotypes disappear because it had not really a relevance to the natural history. Both of these patients had a very poor prognosis, and there was no therapy at that time, at least no effective therapy, so the response to therapy was not really assessed. So another problem is stability of COPD phenotypes, which I think is slightly different from the problem of stability of asthma phenotypes, as Pascal mentioned this morning. One of the problems with asthma is that asthma is a very reversible disease. It varies over time. COPD is less variable than asthma, even though there is some kind of variability. But for example, if you use bronchodilator reversibility to phenotype COPD patients, then this may be misleading. This has been shown by Peter Carvallet 10 years ago, and it has been shown in the ECLIPSE study recently also. If you do bronchodilator reversibility testing every 4 weeks in a cohort of COPD patients, so you start with the cohort, and in orange, the patients respond to bronchodilator reversibility, and in blue, they do not respond. So what you see is that approximately 30% of the patient have constant bronchodilator reversibility. Then you have some patients who have constant non-reversibility to bronchodilator. And then most patients, sometimes they respond, sometimes they do not respond. So if in a cross-sectional analysis, you classify a patient as being responsive or non-responsive, it may really be misleading, so probably you should not use this as a way of phenotyping patients. And further, it has no relationship to FEV1 decline and mortality. So basically, this is not a phenotype. So, how should we identify COPD phenotypes? Well, we have physicians, we see patients, and we can just pick up some characteristics of our patients and say, let's test whether it's a phenotype or not. This is the so-called classical approach. So Professor Krina is here, so he's one of the authors of this paper from the COPD gene study with the paper is called Chronic Bronchitis Phenotype of COPD, and this is a Platino study in the European Journal. Next year, the chronic bronchitis phenotype. So is chronic bronchitis a phenotype? So we have this data from the Copenhagen City Heart Study, which was published now 15 years ago. And in this paper, what they did, they had a large cohort of male and female with COPD, and they measured excess FEV1 decline per year in men and in female, according to the presence or the absence of mucus hypersecretion. So this study was taken 5 years apart. So basically what it says, no mucus, it means that on the first evaluation you declare no cough and sputum, and 5 years later you declare no cough and sputum. The opposite, chronic mucus hypersecretion, both evaluations you say that you are producing cough and sputum. And any mucus hypersecretion means that sometimes you say yes, sometimes you say no. So if you look at FEV1 decline, when you produce cough and sputum, you get increased FEV1 decline, which is more pronounced in male than in female. But in both cases, you get increased FEV1 decline, and this has been confirmed by at least 2 different studies now. But then, is it really a clinical phenotype? So this may be really a little bit small just to see, but what it shows all the studies that have performed cross-sectional analysis of COPD cohort of COPD patients according to the presence of cough and sputum production. So first, if you look for the prevalence of cough and sputum production in these studies, this is, for example, the ECLIPSE study, 35%. This is our study in France, 74%. This is the COPD gene study, and I'm not sure, it's 27%. And this is, for example, Platino study is 14%, so it's highly heterogeneous, and it really depends which kind of patient you're sampling. If your study is based in a tertiary care hospital, if your study is based in a general population study, you have very different things. Then, the prevalence of current smokers among patients with chronic bronchitis or without chronic bronchitis, basically in all studies, when you are a current smoker, you have higher percentage of the population with chronic bronchitis. So it's really associated with current smoking. And then you have exacerbations. So we reported that there were 2 times the more exacerbations, including severe exacerbations leading to hospitalization in COPD patients reporting chronic cough and sputum production, and this was replicated by the COPD gene, and now it had been also replicated by a Belgium study. But for example, in the ECLIPSE study, there was no difference, and nobody really knew why. There was no difference in terms of the number of exacerbations in people with chronic bronchitis in the ECLIPSE study. It's the only study like that. So it's complicated. But then, can we really define a phenotype based on only chronic cough and sputum production? Well, probably not. And this is a rather old study from the Copenhagen City Heart Study. But what it shows, I think, is very interesting. You get the increased risk of respiratory mortality in patients without or with chronic mucus hypersecretion, so cough and sputum production. And what you see is that also the risk is increased in all patients. It's really markedly increased in patients with low FEV1, whereas it's not really increased in patients with higher FEV1. So I think probably chronic cough and sputum production is not really a phenotype by itself. It may help together with other factors such as low FEV1, for example, to identify a phenotype. And it's mostly, I think, a marker of disease activity related to current smoking, to exacerbations, and associated with a very specific kind of inflammation. Talking about phenotype, I think the best proof of the existence of phenotypes in severe COPD patients come from the NET trial, which, as you all know, evaluated lung volume reduction surgery for emphysema. So in this trial, what they had patients with very severe COPD airflow limitation, FEV1 less than 45%, and emphysema, and hyperinflation. And they compared medical therapy, including rehabilitation, as compared to the same therapy plus lung volume reduction surgery. And if you look for the probability of death between both groups, there is no difference. Okay, this is one thing. But then, because the procedure was very heavy, surgery is a highly risky procedure, they had the data monitoring safety board, and they defined that unacceptable mortality was over 8% mortality at day 30. And doing that, they were able to identify two different groups of patients, so-called high-risk patients, small part of the study, about 10% of the study, low FEV1, low DLCO, homogeneous repartition of emphysema. And what you show is that you get an increased risk of death with surgery in this subgroup of patients. Whereas there's another group of patients, about 300 patients, with upper lobe predominance, low exercise capacity, and you get a great improvement with lung volume reduction surgery. So with the same treatment, when you apply it to a heterogeneous group of patients, you have different results. So this is really confirming the concept of phenotypes, I guess. So this was a physician view about it. Now let's go to cluster analysis and mathematics. So if you're doctors, it's because you don't like mathematics. So I will try to introduce you to cluster analysis a little bit. So basically, all this comes to what Pascal already showed you as systems medicines. So what it is obtain data in large cohort of subjects, any data, whatever you want. Clinical data, imaging, biological biomarkers, and then you establish mathematical models. So they have very odd names: cluster analysis, principal component analysis, multiple correspondence analysis, self-organizing maps. So all of this basically means that you have mathematical algorithm that allow you to group patients according to multiple data. So people usually present this kind of analysis are unsupervised and unbiased. And I think it's not unbiased, it's highly biased, because what it does with these mathematical models, it finds structures into data. So it's biased by the kind of cohort that you recruited, by the kind of data that you included, so it's highly biased. And then unsupervised, it's wrong. It's highly supervised analysis. But this is research, and you have the right to use the kind of patient that you can use and to supervise your analysis. But then you have to validate your results, and validations needs to be with strong outcomes such as mortality and exacerbations. And if it works, you're happy. If it doesn't work, you modify your model and back again. So it's really exploratory analysis, and it's not unbiased, and it's not unsupervised. So to give you an example of one study that we performed with the group of Mark de Kramer in Leuven, so what we've done, we took the cohort that he had in his clinics, Leuven COPD patients, and we had the so-called preclinical COPD patients recruited through lung cancer screening in the Nelson study. And we excluded patients who were not COPD. So at the end, we had 650 patients with COPD. And we defined a set of variables that we thought was important for really characterizing a COPD patient. So it was age, body mass index, FEV1, dyspnea, quality of life using the CCQ score, thoracic gas volume, and DLCO. And when you do that, you understand the problem of cluster analysis. We had missing data in 122 patients, so the analysis was performed in a subset of the patients. So there are two ways of dealing with missing data in this kind of analysis. The first way is to exclude patients. The other way is to perform multiple imputation, and some groups do that. But as a matter of fact, nobody really knows the impact of doing one thing or the other thing. And then we followed patients for several months for vital status. So we made our analysis based on these variables that I already talked to you about. And then we had a CT scan with scoring for emphysema, airway sickness, bronchiectasis, and we had all kinds of comorbidities. And we developed algorithms that really allowed us to use a single cluster analysis for all these variables. And we determine the phenotypes based on all-cause mortality. So to give you a sense of what it is, this is a dendrogram. Each line corresponds to a patient. And when this segment is very small, the patients are very similar to one another. And for example, these patients and these patients are very different. So then we have a mathematical algorithm that tells you that the best way to separate your dendrogram into clusters is to have either 3 clusters here or 5 clusters, based on just mathematical calculation. And then you look at mortality. So mortality rates, cluster 1, 0.5%, cluster 2, 20%, cluster 3, 14%. And if you split it here, 14% and 0.7 and 0. So it doesn't add much. So basically, we cut the dendrogram into 3 phenotypes. And what we found that was phenotype 1 was young subject, GOLD 1 and GOLD 2, with limited symptom, limited comorbidities, and limited CT scan abnormalities. And these patients had a good prognosis. And then we had 2 patients at high risk, 2 groups of patients at high risk of mortality. The first group was patients aged 30 years with predominant respiratory disease, very high level of emphysema, dyspnea, hyperinflation, low DLCO. They had very limited number of cardiovascular comorbidities, low BMI, and high level of osteoporosis and muscle weakness. And then at the opposite, the second group was 10 to 15 years older. It has less severe respiratory disease, less emphysema, less hyperinflation. Goal stage was 2, 3, or 4, but 10 years left, 10 years after. And many cardiovascular comorbidities, and also obesity was highly prevalent. So these are very different groups of patients. So because I'm running a little bit short of time, I won't go into great details into that. But we recently wrote a review about all the studies that have used cluster analysis in COPD patients with multiple comorbidities to try to identify phenotypes. And if you go really deep into the studies, each studies are major flaws related to the kind of population people sample, to the kind of analysis they use. So it's difficult to have a very precise idea of what is in all these studies. But basically, the kind of phenotype that we have found, which means the severe respiratory phenotype, and on the opposite, the phenotype with obesity and metabolic and cardiovascular comorbidities, more or less are found in each and every cohort. So in conclusion, COPD classification do not integrate all the aspects of severity in COPD patients. And I think the most important aspects that are not addressed by this classification are age, and age in relation to FEV1 and comorbidities. We have 2 major clinical phenotypes of severe COPD patients that are emerging. The first one is what I would call early onset severe disease and severe respiratory disease. And the other one is multimorbidity in older subjects. And it's very likely that these kind of patients would benefit from very different approaches. For example, if you want to use statins or to use beta blockers, you should probably do your clinical trials with this kind of patients. If you want to show that you have a new drug that prevents the development or the progression of emphysema, you should probably start with the first group of patients. Thank you very much for your attention.
Thank you very much. Very accurate review, and also for the personal approach to the problem. We have time for just one question. The microphone here, please.
Thank you for an outstanding lecture. I mean, you've really clarified, I think, that how very, very complicated COPD is. Two points only. First, in this slide, it's very interesting that this what you find in these 2 groups. One that, you know, I hate to say, but almost look like there is a pink puffer and a blue bloater.
I kind of agree with that. Although the age problem is different.
But one of the things that we have not been considering seriously is that when you have a COPD who is obese, we don't pay enough attention to the possibility of a sleep apnea. And the sleep apnea could account for all the comorbidity, cardiovascular comorbidity, can account for pulmonary hypertension that could really account for, for heart abnormalities also. So I think that we should really, and I always thought that the so-called blue bloater was the COPD who had the sleep apnea. I mean, that's what they looked like. The other thing that I think is extremely important is that we have not paid enough attention, I think, is that in the lung volume resection surgery, I mean, that's I totally agree with you. I think that this is extremely important phenotype, that especially diffuse emphysema and localized emphysema, that I would love to translate that, and I think probably it's not very far out, to panlobular emphysema and centrolobular emphysema. And we know that these emphysemas physiologically and clinically do differ and then behave very differently. And I think that those are the things that we should really talk about. I love how you really criticize all the other attempts to phenotype, and that obviously they don't work. Thank you very much for the lecture.
Well, thank you for your comment. I think regarding sleep apnea, it may be a very important thing. I think maybe to widen it a little bit, it really touched the subject of undiagnosed comorbidities in COPD patients. We know that it may be very high for sleep apnea, that it may be also very high for heart failure, for example. So Pascal was saying, I want to see patients with severe asthma, and to have all specialists sitting in the same table and discussing how you would take into account multiple comorbidities. So I think the main question at the moment is really which comorbidities we need to systematically assess in patients with COPD.
Klaus, short.
Short. To bridge the two topics that we just heard, how I understood the program was inherently how useful is it to have a phenotype? That is what you both had to answer. And I think you touched about one point that I would like to highlight, which I think is extremely important. If you look in time and or severity, which is not necessarily the same, but if you look in time of a disease, for some areas, phenotyping doesn't make sense because they converge. If you have severe disease and more long-standing disease, asthma and COPD converge to some extent. For some other areas, severity or duration of the disease does make it important, because I do believe that, and I don't agree with the chronic bronchitis thing quite obviously, because there are interventions that work on one and not the other. I think there it is very important to make the distinction. So I would want to highlight what you both said. Phenotyping has different role in the different disease severity and or duration. While it may not be useful at end-stage disease because they are indistinguishable to some extent, like a fibrotic lesion, it may be very important to capture the differences early on. Would you agree on that?
Well, somehow yes, somehow no. First, regarding chronic bronchitis, I know that we disagree on that. When you mentioned interventions that work in patients with chronic bronchitis, I presume you refer to roflumilast, for example. Okay, maybe. I think it's not because you've shown that in a clinical trial you can show an effect of a drug in patients with chronic bronchitis that it's really due to chronic bronchitis. It just could be the marker of, for example, higher level of exacerbation. So I think it's a way of study enrichment, for example. And for example, if you look for the story of ICS-LABA, you have several studies showing that ICS-LABA reduce exacerbations, but then if you also have a study on beclomethasone formoterol showing that it doesn't reduce exacerbation, but the problem is that in this study you have very low levels of exacerbation, low rates, 0.4 per patient per year. So I think really what you could use is use phenotypes as enrichment strategies in studies. And this will really allow smaller sample size and shorter time of studies, but it does not really define, I think, a phenotype in which patients really, in which treatment is effective and not effective.